Hi everyone, my name is Pavel Antiprovic, and I'm a Canadian cardiologist currently completing training in cardiac electrophysiology. Today we will be discussing a foolproof approach to SVT diagnoses on single-lead tracings. Ever since I was a medical student, I found that interpreting SVTs to be one of the most frustrating concepts in ECG interpretation. It wasn't until I became an EP fellow that I was taught a very straightforward and logical approach, which made ECG interpretation quite fun. To master this, I had to unlearn my previous techniques, which were based on published algorithms and pattern recognition. In this video, I'm going to introduce you to this approach. First, we will review the basics of conduction, particularly what makes the QRS wide and what makes it narrow. Then we will discuss formulating the differential diagnosis, which is the key to this approach. Then we will discuss the mechanisms of arrhythmia for each item on our differential diagnosis, and then we'll apply these concepts to a series of tracings and assess the onset, the SVT itself, as well as the termination to rule in and rule out certain items on our differential diagnosis list. This is a simplified diagram of the cardiac conduction system. It is composed of the AV node, the common bundle of His, the bundle branches, the fascicles, and the Purkinje fibers, which are not shown in this diagram. The word supraventricular refers to an arrhythmia where the key mechanism is above the bundle of His. These arrhythmias use the His-Purkinje conduction system to activate both ventricles quickly, which creates a QRS that in most cases resembles the baseline QRS. If the baseline QRS is narrow, it will often be a narrow complex tachycardia, barring any rate-related bundle branch blocks. Now, it's important to note the AV node serves as a gateway into the ventricles. And a large portion of the population has more than one pathway within the AV node. One pathway generally has a relatively slower conduction compared to the other. And the faster pathway has a longer refractory period, meaning that it takes longer to recover than the slow pathway. In individuals with more than one pathway within the AV node, what we call dual AV nodal physiology, conduction during sinus rhythm generally takes place down the fast pathway. The slow pathway is often engaged, but by the time the signal reaches the common pathway, it's already depolarized, and the slow pathway is of no consequence, and the person continues to live free from arrhythmia. In a subset of patients with dual AV node physiology, the conduction properties of the pathways are such that an arrhythmia can occur. Consider a PAC that activates the atrium prematurely. The signal is first blocked in the fast pathway, which has a longer refractory period than the slow pathway and takes longer to recover, yet the signal can enter the slow pathway and proceed its way to the common pathway. By the time it reaches the common pathway, the fast pathway has now recovered, and it can come back up the now recovered fast pathway and re-enter the slow pathway again to reactivate that tissue. This forms a macro re-entry circuit that's entirely contained within the compact AV node. This is called typical AV NRT. This diagram illustrates the three basic requirements of a macro reentry circuit. There has to be slow conduction, a unidirectional block, and recovery of the tissue, allowing it to be re-excited. When assessing a tracing for an SVT, it's important to formulate a differential diagnosis list. The differential diagnosis for SVT can be quite long. EP physicians generally group them into four main categories which have distinct properties. Let's go through each of them and discuss them in more detail, starting first with atrial tachycardia. An atrial tachycardia is an SVT where the mechanism is located entirely within the atrium. Examples of this include sinus tachycardia, which originates in the crista terminalis in the superior right atrium. Atrial flutter, which is a macro reentry circuit that involves the cavotricuspid isthmus, which is the space between the tricuspid annulus and the IVC, focal atrial tachycardia, which is illustrated in this diagram, and sinoatrial reentry tachycardia, which is a form of sinus tachycardia. Next, we will discuss AV node reentry tachycardia. The mechanism of this arrhythmia is situated entirely within the AV node, which on this diagram is indicated by this green structure here. Notice that this does not require the activation of the ventricles or the atria to sustain itself.
Occasionally you will see an SVT on a tracing that seems to be missing a P wave or the QRS but continues uninterrupted. This could very well be AV-NRT with a block to the ventricles or the atria for one beat, but because the tachycardia does not require either of the two chambers, it continues uninterrupted. The key feature of typical AV-NRT is the simultaneous activation of the atria and the ventricles. When a signal goes down the slow pathway, it reaches a common pathway and bifurcates. One signal goes down to the ventricles to activate the ventricles and make a QRS, while the other signal comes up the fast pathway and can enter the atrium. This process takes place simultaneously, and on the ECG, it can be illustrated by finding P waves and the QRSs that are overlapped. This is an example of typical AV-NRT initiation. It initiates with a premature atrial contraction, much like it did in the example we were discussing initiation of macro reentry arrhythmias earlier in this presentation. This premature atrial contraction is followed by a long PR interval, which represents slow pathway conduction. After this, you see a QRS and a P wave that are overlapped, and the SVT continues with the P on QRS fashion. Looking at this QRS, I know that there's a P wave in it because I can compare it to the sinus QRS and T wave. If I template the sinus QRS and T wave, I know that there is a high frequency deflection in the tail end of this QRS, which was not there previously. This likely represents a buried P wave. It is important to note that P waves cannot be seen quite often in typical AV-NRT because they're often buried deep in the QRS. However, simultaneous P and QRS are quite characteristic of typical AV-NRT. Other forms of AV-NRT are the atypical forms. This includes the fast-slow variety of AV-NRT, where there's an anterograde fast pathway and a retrograde slow pathway, basically the opposite circuit to what is shown here. There's also the so-called slow-slow variety, where both pathways indicate slow conduction. It is important to note that it is often difficult to diagnose atypical AV-NRT on our surface tracing and distinguish it from the other differential diagnoses, because the P wave is often located in different parts of the cardiac cycle, depending on the patient's conduction properties in each pathway. The third item on the differential diagnosis of SVT is atrioventricular reentrant tachycardia, AVRT. This is a large macro reentry circuit involving the AV node, the bundle of His, the bundle branch block that's ipsilateral to the accessory pathway, oftentimes the fascicle, the myocardium that's close to the accessory pathway itself, and the atrial myocardium. Now, the key property of AVRT is that it requires both the atria and the ventricles to sustain the tachycardia because they're part of the circuit. If the patient develops a conduction block in any of these structures, the tachycardia circuit will either terminate or it will bypass the block and the tachycardia circuit will change. A famous example of this is a sudden development of a left bundle branch block during the tachycardia. If it occurs, the opposite left bundle branch block will become part of the circuit, and the conduction will happen transeptally to the left ventricle and back up the accessory pathway. This would create a much larger tachycardia circuit, which may often slow the tachycardia cycle length, and the VA time will prolong. There are two types of AVRT. There's orthodromic and antidromic. Orthodromic AVRT is far more common, and this is the one that is demonstrated in this example, where the AV node is anterograde and the retrograde limb is the accessory pathway. This is much more common than the opposite scenario because most accessory pathways can only conduct retrogradely. Now, antidromic AVRT is characterized by the accessory pathway being the anterograde limb and the AV node being the retrograde limb. And these are often, or almost always, wide complex tachycardias because the accessory pathway usually inserts directly into the myocardium and does not use the His-Purkinje system of the ventricles to create a narrow QRS. Hence, the QRS is usually wide, maximally pre-excited, and usually not included in a differential of a narrow complex tachycardia. It is important to note that there are multiple types of accessory pathways, and some insert directly into different parts of the conduction system, and discussing these pathways are outside the scope of this talk. Last but not least is junctional tachycardia. JT is a focal tachycardia within the AV junction, and it does not require the atrium or the ventricles as part of its mechanism. Depending on where the JT is, whether it's electrically closer to the atrium or the ventricles, determines the relationship of the P and QRS complexes on the ECG. If the JT is close to the atrium, the P wave will precede the QRS. If it's electrically farther from the atrium or has a delay to the atrial conduction, the P wave may end up after the QRS. And now we're getting to the fun part of the presentation, which is applying these mechanisms to various tracings. For each tracing, I recommend that you pause the video and review it carefully yourself prior to hearing my explanation. When approaching any tracing, never jump into a particular diagnosis. Always start with making a general observation to frame the problem. For example, this is a narrow complex tachycardia. We see the initiation of the tachycardia, the termination, and a few beats of sinus rhythm. The differential for this includes atrial tachycardia, AV-NRT, AV-RT, and junctional tachycardia. This narrow complex tachycardia initiates with a premature atrial contraction followed by a long PR interval. Then we see several beats of narrow complex tachycardia which do not have easily identifiable P waves, and a termination. Now the question is, does the initiation with a PAC and a prolonged PR interval help narrow our differential diagnosis? So let's look at each item on our differential diagnosis list and determine whether this observation can be explained by the mechanism of that particular arrhythmia. Let's first start with an atrial tachycardia. In an atrial tachycardia, it is conceivable that it initiates with a PAC, or the first beat of an atrial tachycardia. Then there's a delay in the AV node called a decrement, which is a response to prematurely stimulating the AV node, and this is a physiological response to a premature stimulus. So yes, this observation can certainly be explained by an atrial tachycardia and is still on the differential diagnosis list. Next, let's look at AV-NRT. As with our prior examples, it is very conceivable that an AV-NRT initiates with a PAC, which blocks in the fast pathway, preferentially engages the slow pathway, and initiates the tachycardia. And the slow pathway conduction manifests as a prolonged PR interval. So yes, AV-NRT can certainly explain this finding, and it is still on the differential diagnosis. Next, let's look at AV-RT. AV-RT very commonly initiates with a PAC, which blocks in the accessory pathway anterogradely, goes down the AV node, where we experience a physiological decrement, as we did with an atrial tachycardia, and then the AV-RT initiates. So yes, this can certainly be explained by AV-RT. Finally, let's look at JT. It is very unusual for JT to initiate with a premature atrial contraction. However, could this be the first beat of JT? It is possible. However, if this is the first beat of JT, then there has to be a block to the ventricles, which is very unlikely that the block to the ventricles and the JT initiated on the same beat. Hence, JT is quite unlikely and can be removed from our list of differentials. Here we have a narrow complex tachycardia that initiates with a PAC without PR prolongation and has the same four differentials that we discussed earlier. Now let's work through each of those differential diagnoses to see which can be ruled out on the basis of this observation. So the first one is an atrial tachycardia. So an atrial tachycardia can initiate with a PAC and does not require a delay in the AV node to initiate. So yes, this can be explained by an atrial tachycardia. Now let's look at AV-NRT. As we discussed earlier, AV-NRT is a macro reentry circuit. where the PAC that initiates it often blocks in the fast pathway, goes down and engages the slow pathway. And the delay in the conduction that's produced by the slow pathway is required because it gives time for the fast pathway to recover, such that when it gets to this area, it can engage the fast pathway retrogradely, can conduct up and re-engage the slow pathway to complete the circuit. So this delay in the conduction is required for AVNRT to initiate. So this observation makes AVNRT less likely. Similarly with AVRT, which is a macro reentry circuit, when it initiates with a PAC, it blocks anterogradely in the accessory pathway and goes down the AV node. This delay in the AV node is required because it allows the accessory pathway to recover. Because by the time it gets to the accessory pathway, it's now had ample time to recover, and it's able to conduct retrogradely to re-excite the atrium, which can continue and form this loop. So AVRT is less likely based on this observation. And finally, in the case of JT, this could very well be the first evidence of a JT. If this JT focus sits very close to the atrial insertion of the AV node, it can come up and make a retrograde P wave, and then it can come down simultaneously and take longer to get to the ventricles to create the QRS. So yes, this could be explained by JT. Determination of the arrhythmia can certainly hold clues and help exclude some items on your differential diagnosis list. This is a narrow complex tachycardia. We're given a termination and we're given 2 sinus beats. The narrow complex tachycardia has the same differential diagnosis list: AT, AVNRT, AVRT, and JT. As you can see, P waves are visible within the narrow complex tachycardia, and I can verify that these are P waves because there's a high frequency deflection on the tail end of the T wave that's not present when I template it against the sinus rhythm T wave. So these are certainly P waves. Now the interesting thing about this tachycardia is that it ends on an atrial activation, on a P wave. Now let's look through each item on our differential diagnosis list to determine if we can rule them out on the basis of this observation. First, let's start with an atrial tachycardia. For an atrial tachycardia to terminate on an atrial activation, the mechanism of an atrial tachycardia would have to stop, and then the last beat of the atrial tachycardia would have to block in the AV node such that it activates the atrium and not the ventricles. To use atrial tachycardia to explain this observation, 2 isolated events would have to happen at the same time, at the same cycle. So the atrial tachycardia would terminate in its mechanism, and the last atrial activation would block in the AV node. It would be quite a coincidence for the 2 to happen at the same time, hence atrial tachycardia is very unlikely. Now let's look at AVNRT. AVNRT can certainly terminate like this. When the propagation goes down the slow pathway, comes back up the retrograde fast pathway, it can create an atrial activation and then come down the slow pathway and block in the slow pathway such that there's no ventricular activation. So this can certainly be explained by AVNRT. Now let's look at AVRT. For AVRT to terminate on an atrial activation, the signal must travel down to the AV node, make a QRS, come back up the accessory pathway, make the last P wave, and then block in the AV node without making it to the ventricles. This is certainly a plausible explanation, and AVRT is certainly still on the differential diagnosis. Now let's look at JT. To explain this observation with JT, the last beat of JT would have to make it to the atria, to activate the atria, make a P wave, and not make it to the ventricles, essentially block below the level of the JT. So 2 things would have to happen. The JT would have to terminate, and the signal would have to block below the level of JT on the same cycle, which is quite a coincidence. So hence JT is quite unlikely on the basis of this explanation and can be ruled out. This is a tracing of a narrow complex tachycardia. Next, let's talk about the concept called VA linking. Here we see two sinus beats and initiation of a narrow complex tachycardia, which has the usual differential diagnosis of AT, AVNRT, AVRT, and JT. This narrow complex tachycardia initiates with a PAC followed by a slightly prolonged PR interval. And as we learned in the previous example, this does not help us rule out any of the differential diagnosis items. However, there's something here that may be helpful, and that's called VA linking. The VA time is measured from the onset of the QRS to the next P wave, and it can be measured over several cycles at the initiation of the tachycardia. As you can see, there's slight wobble in the cycle length of this tachycardia. However, the VA time stays completely fixed. This suggests that this QRS is mechanistically linked to the following P wave. Now let's use this observation to go through our differential diagnosis list to see what we can rule out. In a case of atrial tachycardia, each cycle initiates with an atrial focus, then you have an atrial activation that produces the P wave, which then conducts to the ventricles and activates the ventricles to produce the QRS. Each QRS that's produced is related mechanistically to the prior atrial activation or the prior P wave and has nothing to do with when the next atrial activation will take place. So the VA linking helps rule out an atrial tachycardia. This is especially helpful at the beginning of the SVT when then there is a wobble in the tachycardia cycle length, which can be caused by the PR prolongation or simply a ramp up and ramp down phenomenon of an automatic atrial tachycardia. Now let's look at AVNRT. With each cycle of AVNRT, the slow pathway engages the fibers that lead directly to the ventricle and the atria. So the ventricles are linked to the atrial activation. So certainly AV node reentry is possible. Now let's look at AVRT. With each cycle of AVRT, the signal goes through the AV node, makes a QRS, and then comes back up and activates the atrium. So each P wave is mechanistically linked to the prior QRS. So VA linking is possible in AVRT. Now let's look at JT. With each beat of JT, there's a signal that goes up to activate the atrium, and there's a signal that comes down to activate the ventricles. Both of them are linked together as well. So presence of VA linking does not exclude JT. So the only thing that is excluded by VA linking is atrial tachycardia. In this particular example, the VA is not linked. Go ahead and work through each of the differential diagnoses to determine what can be ruled out. You'll find that none of the differentials can be ruled out. The retrograde limb of macro reentry circuits, the one that causes atrial activation, can decrement, which can prolong or shorten VA time. Hence, absence of VA linking is not helpful in ruling out any of the diagnoses. The last feature that we'll talk about that will help you with your differential diagnosis is the AV relationship, or the RP time. The RP can be very short, and almost so short such that the QRS and the P wave are overlaid on top of each other, and you get the summation of the waveform. The RP can be slightly longer, but less than half of the RR cycle length, and in this case, this is considered a long RP tachycardia, where the RP is much longer than half the cycle length. Now let's look at the case of a very short RP tachycardia. In fact, the VA time here is so short that the P wave is merged with the tail section of the QRS. Now let's work through all our possibilities to see what we can rule out. If this is an atrial tachycardia, this P wave would represent the atrial activation, which would be followed by a long PR interval, which would represent the delay in the AV node before ventricles can be activated. So the patient would have to have a first-degree AV block during atrial tachycardia for it to be explained by this observation. It is possible, but not very likely, so we can put atrial tachycardia lower on the differential diagnosis list. Next, we can look at AV-NRT. In fact, what you'll find that this is actually a classic case of AV-NRT, where the slow pathway engages both the fibers that lead to the ventricles to cause a QRS and the fibers that lead to the atria that cause the P wave. Those fibers are engaged simultaneously. And so the AV time, or the RP time, in the case of AV-NRT is a pseudo-interval. They take place simultaneously, which is why the QRS and the P wave are often overlapped. So in this particular case, AV-NRT is the most likely diagnosis. Next, let's look at AV-RT as a possibility. In AV-RT, the signal must pass through the AV node, depolarize both ventricles before it can turn around and re-engage the accessory pathway to create another P wave. Generally in AV-RT, the P wave must be separated from the QRS. So a lot of electrophysiologists would look at this and say the VA time here is much too short for it to be AV-RT, so it can be safely ruled out. And finally, in the case of JT, with each JT focus, with each JT cycle, there is also a pseudo VA interval where the fibers are engaged that lead to the atrium and the fibers are engaged that lead to the ventricle at the same time. So it is very likely that this could very well be JT. AV-NRT, or typical AV-NRT, is far more likely and more common than JT. So it's still higher on the differential diagnosis compared to JT. Finally, let's look at the case of a long RP tachycardia and play through all the scenarios. In the case of atrial tachycardia, this could be an atrial tachycardia if this P wave represents atrial activation followed by ventricular activation. Although most would say this interval is far too short to represent physiologic PR interval. Although it could be long enough, it's hard to say. Atrial tachycardia is still a possibility here and cannot be ruled out. In the case of AV-NRT, this cannot be a typical AV-NRT because there's such a long delay between the ventricular activation and atrial activation. So this has to be a typical AV-NRT, but it's always a possibility. Atypical AV-NRT can explain any RP interval or any AV time. In the case of AV-RT, this could be AV-RT. However, when the ventricle is activated, there's a long delay before the next P wave is formed. So if this pathway is decremental or very slowly conducting such that it creates a very long VA time, it is possible. So AV-RT with a decremental retrograde accessory pathway is a possibility. And finally, with JT, it is a possibility if the JT focus is very close to the atrial entry into the AV node, such that when it fires, it creates a retrograde P wave and then takes a while to create the QRS, which is why the QRS comes after. So the JT is also a possibility here. To summarize, a highly effective approach to arrhythmia interpretation is to initially make an observation about a tracing and frame the problem. For example, this is a narrow complex tachycardia. Then present the differential diagnosis and play out the mechanism of each differential against the tracing to see what can be ruled out. We discussed a number of scenarios here, but this is certainly not exhaustive, and the more you'll practice, the better you'll get. Thank you for your time, and I hope you enjoyed this presentation.